Good afternoon and welcome to Public Health Network Cymru's webinar series. My name is Christian Heathcote-Elliott and I'm the Principal Public Health Practitioner for the Wider Determinants of Health Unit in Public Health Wales and will be today's facilitator. Today's webinar focuses on describing the key factors which influence our choices and behaviours and why a better understanding of these factors can make more effective public health interventions and impactful policies. To illustrate this, our speakers will be focusing on adherence to COVID-19 interventions, including social distancing and mask wearing. I'm therefore delighted to welcome our speakers, Ashley Gould, who is a consultant in public health and Programme Director of a newly established Behavioural Science Unit in Public Health Wales, and Dr. Simon Williams, who is a lecturer in psychology at Swansea University and adjunct assistant professor at Northwestern University in Chicago. Ashley, in his previous role, was the National Lead for Tobacco Control in Public Health Wales, who had responsibility for strategic leadership on action to reduce smoking prevalence and used the application of behavioural science to increase the number of smokers accessing NHS quit support. During the pandemic, he had roles in early contact tracing and National Health Protection Cell, and since 2020 has focused on the application of behavioural science to the pandemic response in Wales. He is co-chair of the Risk Communication and Behavioural Change subgroup of the Welsh Government's TAG. Simon, with colleagues in Swansea and Manchester University, has been leading on the Public Views of COVID-19 project. This is an ongoing longitudinal research which explores people's experiences and attitudes during the pandemic, including themes such as adherence, infection-reducing behaviours, and interventions around vaccine hesitancy. I will now give you some housekeeping rules before I hand over to Ashley and Simon. So after the presentation, there will be a chance to answer questions. Please use the question and answer box to type in your questions. Be aware that all your questions will be seen by all attendees of the webinar. Secondly, this webinar is being recorded and it will be made available on the Public Health Network Cymru website after the completion of the webinar. English and Welsh subtitles are available and these can be switched on using the button at the bottom right of your screens. And if you do experience any difficulties during the webinar, please put this in the chat box and one of our team will be there to support you. So without further ado now, I would like to hand over to Ashley first of all, who will give his presentation, and then we will move on to Simon's presentation. Thank you.
Fantastic. Thanks very much, Christian. Can you hear me? All good? And you can see my slides. That's great. So thanks very much for the kind introduction. And thanks to Simon as well, because he initiated the idea of putting together the webinar. So Simon's in the lead. I'm just happy to go first and be the warm-up act for Simon. So Christian's given you who I am and my role in this. So I'm going to spend a little bit of time going through these aspects. I'll talk about where we're coming from, our foundation, some headline considerations for us all when we're thinking about behaviours and behaviour change, then roll that together into some essential steps for using behavioural science to improve health and well-being particularly. And then I'll highlight three key tools. I'll unpack those acronyms. Apologies for them now, but I will get into each of these three. And then a slide or two around how we've used some of that science to respond to SARS-CoV and the COVID pandemic, and a final slide on the new unit Christian's just mentioned. So our starting point of these five. What's behavioural science? It's a systematic study of behaviour. And what's behaviour? It's activity in response to a stimuli. That can be external stimuli or internal stimuli. We're interested in what enables it, what prevents it, and how best we can elicit that behaviour for social good generally. Second starting point for us is critical around the who. Are we trying to get to do what? And why not? That drill to understand their barriers and their enablers. And then the selection based on that unpack of selection or co-production ideally, and testing of interventions in the way that Christian's described, be in policy, be in service, be in projects, be in communication. That's what I mean by intervention in that sense. Ones that are most likely to elicit the target behaviour in the target population. Third point is that we're recognising the mix of cognitive, psychological, social and environmental influences over people's behaviours, and the fact that they differ depending on the segment that you're dealing with. And understanding why and how that mix is working and why and how people would or aren't undertaking a target behaviour is critical, rather than relying on, where we tend to go to, me included, an assumption that the default is that the target group, they, are lacking knowledge and need advice, and we'll give that in any number of ways that we can. So it's challenging that assumption in the production of our work, and leaning them more towards the best tool for the job. So thinking up and developing interventions based on evidence as well, to fill behavioural determinant gaps, and then engaging with populations and segments thereof, and evaluating what we're doing. So that's the sort of foundation stones for our approach to behavioural science. And then some headline considerations when we're moving on from that, things that none of us have got as humans, and things to reflect on as we think about our work. So none of us have got perfect information and decision making, however much that we'd like to think that we have. We've got 5 times as much information flying at us at the moment compared to 30 years ago. What that gives us is fatigue. It makes us feel tired. It leads to the generation of heuristics, rules of thumb, that lead to suboptimal decisions. Some of our responses to that then in the way that we work can be around breaking things down to the individual behavior, not a policy aspiration, but the behavior. Describe that response to a stimuli. We can use defaults. We can identify those rules of thumb that people are using, and we can decrease the hassle for them. None of us have got unlimited cognitive ability. What that leads to is an inconsistency, what seems to be illogical responses, and it leads to cognitive bias for us. That in that space of heuristics, we make quick decisions because of what we've seen in the past. How do we counter that, or try to? Well, we can frame with values in mind. What do people hold dear, and how do we build that into the areas of activity that we would want them to follow, the behaviours that we want them to follow? We can add that in. Useful to recognise that the more choice we give individuals, the more likely they are to stick to where they are, because of that limited cognitive ability that we've all got. So think about that in terms of choices and our design of our architecture, our choice architecture. Think about that in terms of our interventions. None of us have got total self-control. We live in the moment. It's recognized it's not a flaw, it's just a part of human nature. Immediate hedonic behaviors, quick reward, will invariably trump distal benefits that are further away. That's just a fact. How do we counter that? Well, we can prompt people to do the things that we would like them to do, the pro-social behaviours, when they're receptive. So it's about timeliness. We can illustrate the immediate benefits of undertaking that behaviour. That helps counter that lack of self-control, when I phrase it like that. And we can use commitment devices. So if you undertake to do a behaviour, particularly socially, publicly, you're more likely to do it. How do we build devices in like that? And then none of us have got an ignorance of fairness or welfare of others. So it's useful to recognise that we are social creatures. Our actions and choices are linked to our social and or professional identity. There's a lever to pull in terms of us designing policies, services, communications, projects. So we think then in that way about the messenger. Who's the messenger? Who would I identify with and listen to more? Most people like me are doing this kind of thing, that kind of messaging around social norm, are most likely to lead to where we would want them, where we'd want the behaviours to be. So pulling those 2 first slides together, these are 3 essential steps that the Prevention and Behaviour Change Cell within Public Health Wales pulled together mid-COVID. We were applying behavioural science well before that in the way that Christian has described, but in the white heat of the response to COVID, we needed to crystallise that into some steps to help others use behavioural science. So it got crystallised very much down into 3 steps, and these are they. So defining the problem to start with. So which behaviour, which population? describing that behaviour, not the policy aspiration. What is the response to the stimuli? What is the behaviour? Define that really well in terms of when, where, how long, and why, and describe the current and the desired behaviour if there are differences in those. Identify that population segment, that important group, by any number of metrics that I've got up on the screen there. And then get under the bonnet. Let's understand what's eliciting or disabling that behaviour. And we can do that through engagement. We can walk in their shoes of the target audience, or we can critically reflect on interactions we might have had with that group previously. There's a sliding scale there of proportionality. How much time and resource have we got to do this job? That's a key learning through COVID. And then use a recognised framework to capture what's behind that behaviour. I've used the COM-B model up here, and I've got a couple of slides, so I'll unpack that in a second around that. And then it's about identifying the gaps and plugging them in the way that I've described. So to enable, elicit, and evoke the behaviour that we want. So which tool for which job? Are we talking about education? Often a default, but not always the right one. Are we talking about persuasion, incentivization, coercion in a professional sense? I mean, not in the common dictionary definition of it, perhaps. Is it about training? Is it about restructuring our environment to lead us in a certain direction? Is it about modeling, showing those people like me doing things like that kind of activity in shorthand? Or is it enablement, a mix of those factors? And thinking about interventions that are powerful for and in that segment. So I'm back right to the top of which population exactly are we talking about because of that differential in cognitive, psychological, social, and environmental influences on behaviour. Co-production being the gold standard way of doing that, and checking these factors. So APIs is a recognised tool. I'll expand on it in a second. So that's a quick three-step process that can be used, and there was a link in that slide for that. So I mentioned COM-B in the previous slide, a well-recognized model for and framework for systematically unpacking the influences of behavior that we've used endlessly over the last couple of years around COVID personal protective behaviors. So capability. Have people got the physical skills, the fundamental physical skills to do the thing that you want them to do? Have they also got the psychological capability? Do they know how to do it? Will they remember how to do it? Have they got the attention span? I don't mean that derogatively. Have they got the attention span to hold on to that behavior and carry that through? Have they got the decision-making capability to do that? So those areas of capability are fundamental. Opportunity is around the stuff. It might be access to the stuff to do the behavior. It might be about access to services. It might be about the environment where people live and work and learn and grow. Are they conducive to that behavior? Have they got the right systems and processes around them and the right support? And also in terms of opportunity, have they got the social opportunity? And that is often down to what's commonly known as peer pressure, but it's about social influences, extremely powerful determinant of behavior that can help and hinder follow through on behaviors. And then finally around motivation. So that motivation interacts with opportunity and capability, and motivation can often fill smaller gaps in terms of opportunity and capability. If you want or need to undertake a behavior, the motivation can help overcome some of those gaps. So does it fit with who they feel they are? Does that behavior? Do they believe that it will work and help them get to where they want to be, their goals? Crucial factors in terms of motivation. So this kind of systematic approach is helpful in unpacking the determinants of behavior. Second tool worth highlighting then is the behavior change wheel, again from Mitchie and West. I popped a reference in the bottom corner here. So the previous slide talked about the green circle, those physical, psychological, automatic, reflective, physical and social determinants. The red circle then is about filling the gap. Which intervention type is most suitable? So if we've got a psychological capability gap, we don't know, then training and education might work. Restrictions are not going to be the way to deal with that. Modeling doesn't work. Modeling works if we're looking at a reflective motivation gap. So this is very much about selecting the right tool for the job. And then how we implement those intervention types is on the outer circle. So we're thinking about legislative, we're thinking about communication intervention, environmental and social planning guidelines, the right tool again for the right intervention type is important to make sure that we best implement them, and avoiding that pothole that I hinted about earlier on, the mismatch of this is a knowledge gap. We'll tell them and then we'll tell them again, because that can backfire. There's a mismatch of telling people what they should do when they might already know. So now we're patronizing, or they don't believe in the benefit. So why should I trust that messenger now with that message? Or something material is in their way. I can't get to the vaccination station. You keep telling me that I should do it, but I cannot get there because it's too far away. Or they don't think that anyone else like them is doing that thing that you've told them and you keep telling them to do. So trust goes down again, a critical determinant of whether people follow through on advice. So this is just sort of a warning message. Third key tool, just to highlight really quickly, and you can search this up again, it's from Robert West, who leads in this area, is the appease criteria. So when we've got to the point of who, what, why not, and we're thinking about that intervention design and the behavior change wheel, the appease criteria is critical as well. So how acceptable is that going to be, both for the target stakeholder, but then if you want to get it scaled up, go in a little bit wider than that. How practical will it be? Again, for the individual, but for scale up, have we got the resources and the personnel in place to make that happen? How effective is it going to be? Is it going to get us to where we want to be with our policy aspiration? How affordable is it going to be? Excuse my dogs in the background. Any spillover effects are critical, and that's critical in terms of equity of impact, which is particularly highlighted as a sixth factor here. I'll move on quickly then to the way that we pulled a lot of that theory into the response that's gone on over the last 2.5 years in relation to SARS-CoV. So 6 months in, a little bit over 6 months in, WHO recognized that we control this pandemic with our behaviors. So that's the centrality of behavior change and behavioral science in the pandemic response. What we saw was altruistic, not panic-prone public behavior, and personal protective behaviors were extremely common. They became the social norm. I'm sure that we'd all appreciate that. And Simon's going to unpack that in his talk now. The way that we deliver that, the mechanism, was through this risk communication and behavioural insights subgroup of the technical advisory group in Welsh Government. A bit of a mouthful, so we often shorten it to RCBI. And that's a group of academics, of Welsh Government technical advisors, vaccination policy and comms guys, and other academics that we pulled in throughout. A really talented and dedicated bunch of professionals that it was fantastic to work with. What they did was offer evidence-based technical and policy advice from March 2020, and we're still running at the moment. That technical advice was around segmentation and insight gathering, like the public views of COVID work that Simon will unpack now. It was about intervention design. We offered policy advice around co-production, the use of the rationale, the why, the motivational key to unlock some of those things that I mentioned earlier on, using the equity lens. SI there stands for self-isolation payments to enable. So people had the capability, they knew what it was, they had the motivation, they wanted to do it. They had a social opportunity gap, which was I can't afford to do it. The self-isolation payment helped plug that gap in many cases. We offered advice around COVID passes as well. Lots of stuff on communication, which message, which messenger, using risk communication theory and practice, using social norming, specific work around the vaccination program, shaping the invite letters, talking to tenant groups, focusing in on a segment, the yet to attend, not did not attend, yet to attend, what's getting in their way, and what can we do to fix that? And we worked on the test, trace, protect scripts and did sessions with the communications teams across the piece. Shaped the guidance that went in to keep Wales safe, the public guidance, and then guidance was issued from the risk communication behavioural insight subgroup at these key points throughout the pandemic, all published. Lots of it based on collaboration across Wales in the way that I described earlier, up the top here. UK-wide as well, similar groups working across the UK, the 4 nations, and occasionally wider than that, connections with Canada and Australia particularly. And we did some empirical work as well, observation of mass events when they started to open back up in very controlled environments, and thinking through the ABC, antecedents, behavior, what comes before the behavior, what is the behavior, and then the consequences. How do we, what happened after that, and how do we change that? And final point then about the ongoing learning. I've done this no justice in these 6 bullets, because this is an absolute mass of work and dedication and output from a great group. But we are thinking about the use and utility of behavioural science in terms of vaccination for flu COVID as we go forward, but others that are on the routine schedule as well, about other communicable diseases, some that which are in the news now. But wider than that, then thinking about climate change and sustainable consumption, how do we apply behavioural science to max that out in terms of those pro-social behaviours? How do we ensure that practitioners and organisations have got this knowledge, skills, opportunities and support to do what we just described? And how do we maintain the collaboration that has served us so well over the last couple of years? Academia, government, the public sector, the third sector, and particularly the public. So it's a really rapid run through on COVID, and then just a couple of bullets. So Christian mentioned we've got a new behavioural science cell. A behavioural science unit in Public Health Wales, with a mission of providing specialist expertise in behavioural science and developing the application of it to improve health and wellbeing in Wales. We're a focal point for the World Health Organization's Behavioural and Cultural Insights flagship under their 2025 strategy for better health. So we're really plugged into the learning that's gone on both through COVID and before about using behavioural science. We're close to publishing a guide on using behavioural science in policy and practice with Professor Robert West from UCL. Got some work with Bangor Uni about understanding capabilities in operating environments, and linked to that, work with local public health teams to build that up. We are developing an online repository for these kind of things to help in the application of behavioural science, and a couple of guides as well to again help people with the application of it. But we're determined to use the science to increase the use of the science. So thinking about capability, opportunity, and belief that this will make a difference in delivering a better Wales. I've put the Twitter handle out on the side here and an email address down the bottom, both replicated on this slide. Hopefully timing works. So now I'll hand over to the expert. I'll hand over to Simon. I'll stop sharing my screen and then Simon's can load up his slides. There we go. Over to you, Simon. You're still on mute. Oh. Got your slides. There we go. Got you.
There we go. Brilliant. Yeah, you would think by now I would forget to, or not forget to unmute myself. So yeah, thanks so much for having me. I've got to say, I do challenge one thing Ash just said. He said that he was the warm-up for me. In fact, I think Ash is more like the main event, and I'm kind of like a cool down, should we say, just to make sure nobody sprains or strains themselves after that intellectual high-intensity workout. And a real sweeping kind of overview of behavioural science, phenomenal, really, really helpful to me, and no doubt many here. So thanks for that, Ash. And thanks to you all for having me. I think actually it's a nice segue into our research, because many of the themes and theories that Ashley mentioned, we've actually been trying to explore some of these in our empirical research. So I'm going to kind of whip through some slides, hopefully not too fast, but again, always happy to elaborate more in questions afterwards. You know, as Ash mentioned, we've been running this longitudinal study called Public Views during the COVID pandemic with a really broad remit in mind initially. Of course, it's a cliche to say the pandemic was unprecedented, and we wanted to explore what that meant, you know, at the kind of the micro level for people living through the pandemic. And so initially we had a broad range of objectives, everything from mental health, how were people responding to and feeling during lockdowns as they emerged, through increasingly to a focus on adherence and the types of behaviours that Ash has been referring to non-pharmaceutical interventions, and we felt this was really relevant to public health policy, to what extent people were adhering, and particularly because we are a mixed method study. A lot of big questionnaire survey studies that dwarf ours in terms of size and scale, but our strength was twofold. One, I think it was the rapidity that we got underway. So we started collecting data in March 2020, right during our first lockdown. And then the second strength, I think, was the depth. So again, many repeated waves of focus groups with a high retention and the same cohort of people. I'll give some demographic stats as just to give you a glimpse of the types of people we were talking to. But really trying to get at those why questions and how, and again, through to how people are feeling, and not so much percentages on things like level of compliance, but again, why people were, and particularly why people weren't able, willing, or capable of adhering. I'll get into that in a minute. So data collection is ongoing. And there are some publications again, which, happy to, most of those are open access, but happy to share copies for those who would like a deeper dive. Just as a kind of brief survey, as somebody delivers a package, I'll keep talking, of the timeline. So again, we really got up and running early on, March 2020. We had 3 kind of rounds of focus group data collection during that first lockdown, through to into the summer. A second kind of, or a 4th round really, but a second time point of data collection in the autumn 2020 around the firebreak or lockdown 2 in England. Another round in early 2021. And then the most recent wave, even though data collection is currently ongoing for time point 7, around the time of November, December 2021, where of course Omicron started spiking in the UK. So I think, again, one of the strengths we have is this prospective real-time collection of data that we can now look back and longitudinally follow how people were adapting and feeling over time. We published quite early, 15th of April was our first preprint. And many of these findings, of course, now are commonsensical and axioms within the COVID research world. But at the time, we were again trying to explore what people were feeling in this really unprecedented situation. So again, unsurprisingly to those involved and those who lived through it, which is all of us, there was this theme of loss really. We found these practical losses to do with social interaction because of the lockdown, losses to income for those particularly in precarious jobs, and just a general loss of structure and routine snowballed or kind of manifested themselves then in these psychological losses over time, where people reported feeling like a lack of motivation and self-esteem, a loss of self-worth, and of course reporting symptoms of depression and anxiety. We did simultaneously collect survey data, which we've been analysing as well. And again, it's unsurprising, of course, that we saw many impacts on mental health during the pandemic. But we also started looking early on at adherence, and what we tended to find is that there was reports of high self-adherence, but quite a large proportion of people perceiving and responding to non-adherence in others. And this kind of speaks to that, social norm that Ash referred to, which there were concerns in a sense that, the perception that other people aren't adhering or nobody else is following the rules, why should I, might actually end up being a self-fulfilling prophecy. But, at the bird's eye view, I think what we can see in ours and others' research is that actually compliance was consistently quite high, particularly, if you look at some of the big studies down, for example, in UCL, the COVID social study, we see things like majority compliance, which is where most people are following most of the rules most of the time, has been, really high throughout. So we kind of questioned again whether there was this kind of, psychological fundamental attribution error at play, which is where, again, people tended to, perhaps influenced again by media narratives around rule breaking, tend to feel that, others were so-called COVIDiots or rule breakers, and that was a more prevalent phenomenon than it was. But then if they were to refer to their own instances of, non-adherence, it was more situational. For example, I need to go to work, my employer won't support me not to, so I can't self-isolate. So we just had this kind of interesting kind of dichotomy between people reporting, I follow all the rules, but nobody else does, but many others don't. We had, for a qualitative study, a decent sample size, we were quite pleased with the kind of diversity, if you like, of the sample in terms of kind of representation of ethnicity and gender, mostly focused around England and Wales. A couple of limitations, for example, we would have liked to have recruited a good deal number of older adults in the sample, particularly because many of them, of course, were shielding in the early stages, and many of whom were relatively clinically vulnerable to COVID. But nevertheless, I think we had a decent sample, and certainly retention has been very high. So many of you will be familiar with or sick of cheese, quite literally and figuratively. But of course, the Swiss cheese model of pandemic defences has been referred to as being quite a useful heuristic, I think, for many policymakers, and the Welsh government have used it, and it's been reported and featured in many senses. We kind of found this also to be a fairly useful framework within which to explore our data. And I think, the important takeaway from here, and it really, I think, reiterates less eloquently what Ashley was talking about, is that, any given error, in this case, some kind of infection risk-related behaviour, particularly where it pertains to not following a given rule or piece of advice, is never solely or rarely solely the responsibility of the individual. It has a whole host of social, cultural, and policy systemic conditions and contexts that kind of help to either make these kind of accidents more common or more likely, or help to reduce them. And of course, as Ashley was talking about, the job of public health policy then, as I would see it, is to kind of to minimize the likelihood of these latent conditions, these systemic conditions that could give rise to more than usual errors or accidents, in this case, opportunities for transmission above and beyond what might be considered acceptable. And, we have the time, and this isn't the place to go into the background here, but of course this has a fairly substantial and established literature, propounded by James Reason, the psychologist, where everything from medical error through to occupational hazards, where this model has been quite useful. And that's just another way of depicting it, really, again. So these management decisions and organizational process from the top down, really, government through to those who are implementing higher level policies at the grassroots public health level, all work to potentially minimize the latent failures in defenses and to reduce the likelihood of what Reason refers to as errors or violations. And again, I'm whipping through this, but I think this is where our work comes in, because we were working backwards from people's everyday lived experiences and behaviors and perceptions around the pandemic. We were obviously interested in the different types of non-compliance. And of course, these media tropes around rule breakers were quite oversimplified. But what we found actually is that, as we read this kind of theory side by side, and we also were interested in the COM-B model, I think that's really helpful as a heuristic for this type of research. As we read through these, it became clear that there were different types of non-adherence. One of which was what we might refer to, building on this model, as violations, these kind of deliberate rule-breaking exercises, an intended action, and more often than not, where in our study rule-breaking, if you like, was, or as I think the former health secretary referred to as rule bending, did occur, it was often unintended or unintentional, and this again goes for other domains, for example, occupational hazards and medical errors. There's far more unintentional rule breaking or non-adherence than intentional. And so we thought this was interesting to explore in a bit more depth, everything from attentional failures, and I'll give a few examples that I think might be a good discussion point for future, through attentional failures, memory failures, and then what Reason referred to as slips or lapses, judgment or attention. And then mistakes, which is a slightly different category of unintended non-adherence, which is, either the misapplication of a good rule, which could be because that rule, that guidance is not being clearly communicated enough, again, something that Ashley touched on, or because the rule in and of itself is a quote-unquote bad rule, but again, perhaps because it's not fully thought out or isn't necessarily implementable in the way that it should be. And I think one of the big things that we found from our research is this knowledge base. As Ash was saying, this idea of, as human beings, of course, we have limited cognitive ability and capacity. And as the pandemic drew on, as more and more knowledge and information was coming at us, quite literally in waves, and many people struggle to keep on top of that. And thus, there was a lot of unintentional, if you like, non-adherence. So we could probably debate how to fit these very real world examples into this taxonomy, but this is just my attempt at doing so. So, again, slips and lapses, things like misjudging the 2 meter distance, that was in a lot of surveys, whether that was YouGov or Ipsos Mori, the rule that people admitted to flouting the most. And I think part of that is, again, this debate around how easy that was to implement on a daily basis based on our long-standing habits of wanting to be close to one another as human beings. And then, there's useful distinctions between, slips and lapses, this idea of, we've all no doubt been guilty of forgetting to leave the house with a face mask and either having to go back, or some people perhaps not doing so, being a slip of related to memory, versus, a violation where you might look at something that is deliberately not wearing a face mask when required. But I think that kind of middle tier for me has been most kind of evident in our research. These kind of misinterpretations of rules, whether that was what constitutes essential items in shops, or the misinterpretation of guidance when we had different rules in different regions and different nations across the UK. And I'm not sure why I've put having a party twice there, but allegedly, apparently there were many deliberate parties that occurred during various points of the pandemic. Moving on. So again, with that kind of big framework and context in mind, we found in our data, 6 main themes. I can't go into these in detail now. I'd rather leave room for questions at the end. But one of the big things that we think is of use, perhaps particularly in policy, is this notion of alert fatigue. The concept originated in research on clinical decision-making support systems, where the gist is that, as a medical practitioner or in other occupations, the same applies. Having too many alerts kind of desensitizes people to that alert and that kind of constant information, which in turn can cause important alerts to be ignored and along with unimportant ones. We kind of learn to kind of switch off, or we become kind of information overloaded. And there was actually some kind of theoretical work done on this of what, and looking back to previous epidemics where, again, this kind of influx of information was in some ways counterproductive. If you recall, of course, very, I think in well-meaning attempts to be transparent and to provide the public with daily updates, in some ways at a kind of operational level, for some people was quite counterproductive because it was just kind of too much, and people reported, at least in our study, becoming confused with the rules. And I think that is also reflected in other people's research. So the danger then becomes that potentially important information is harder for the public to kind of sieve or sift out or through. And again, I won't read these quotes out in their entirety, but it's in our +1 paper. Again, I'm happy to resend the link. But it's where people would say, it felt hard to keep up to date with all the information. I'm not as concerned about following the measures as seriously as I should have done. If only we had fewer updates and we concentrated just on the rules, individuals might concentrate more. So again, it's this notion of having almost too much information at hand. The other thing that kind of came through increasingly was this notion of inconsistent rules, both internally inconsistent in the sense that people would question to what extent rules would contradict one another, or to what extent rules would apply in one context and not in the next, or may apply to some people and not others. That was something that people increasingly picked up on and kind of were using, at least in their narrative, to kind of undermine their sense of to what extent people were adhering to those rules. And a big recurrent theme again was the kind of inconsistency between different, in the UK context, different nations, and also around the time of the tier system. I think that was something that was quite difficult for people to entertain. Again, you know, and adjust to as more rules changed across time and place. And yes, I mean, this again is perhaps an obvious theme, but I think trust has been a big predictor, and not just in our research, but also in many other people's research, you know, across numerous countries, the US, Denmark, etc. Trust seems to be one of the big predictors, or confidence in government seems to be one of the big predictors of adherence again. So for us, and it's unfortunately quite timely, I think, you know, we would hear reports that would say, well, again, you know, if people want high adherence, then leading by example is really a key way of doing that, and also communicating clearly what is expected of the public. So I'm mindful of the time. I did just want to briefly, if I can, give at least a little flavour of the other kind of related piece of research we've done on this, which is looking at vaccine attitudes. In part, particularly because Ashley did kind of mention it. This idea, I think, of vaccine hesitancy. I mean, we were quite keen to push back on the association, that not so much within the public health community, but certainly again, this kind of media level kind of discourse would tend to kind of paint vaccine hesitancy in the same light as anti-vax, and we found that was certainly not the case in our study. In fact, there were relatively few we would class as anti-vax, but certainly there were a number of those who were vaccine hesitant. But we kind of, building on this model, the World Health Organization's vaccine hesitancy continuum, we wanted to look at vaccine hesitancy as a dynamic rather than a static concept. That again, that it was on this kind of continuum really, where people would report not really having made their decision yet. So we kind of used these three main groups of acceptors, refusers, and delayers, and those were again at any given point in time, because of course some of those who were quote unquote delaying their decision would become an acceptor over the course of the study. So it's been quite interesting, and we're publishing some work on this quite shortly, hopefully, which will be more illustrative of how people's decisions changed over time. And again, so we just found three main facilitators. The role of social norms was key. Vaccination as a necessity, this idea of, well, I'm going to have to get it because I want to travel in the future. Trust in science and association of science was key to those who were kind of quite pro or quite early adopters or acceptors of the vaccine. And many of these barriers will be familiar, but again, we've kind of unpacked in a bit of qualitative depth. This idea of a preference for natural immunity, which was quite pervasive for some people who are hesitant, even you know, well into 2021. This idea of I'd rather get the virus and get my antibodies that way. And of course, you know, misinformation is a key theme, unsurprisingly there. So just, you know, one thing to, again, in the interest of time, one thing to identify, I think, is that, you know, one of the big differences that we found is that, you know, vaccine acceptors tended to talk about vaccination in terms of the collective. Again, getting back to, you know, something that Ash was talking about, really, this notion of us being social beings or creatures. And so, you know, they volunteered this kind of framing in a way of, you know, I'm getting that even young adults would say, well, I personally don't see myself as being at high risk, but I'm getting it in order to protect others, or in order to free up society, you know, at a time where there were restrictions or protections, you know, implemented at the policy level. Whereas those who were kind of, you know, resilient refusers, in the sense that they, you know, at the last point of data collection still have opted not to get vaccinated, tended to frame vaccination as an individual act, and this sense of any coercion or even soft coercion around messaging was deemed to be a kind of a potential infringement of this individual right to accept or refuse a vaccine. And then just briefly, I think this is probably a good slide to end on, without going into some of those barriers and facilitators in more depth. we did see two main reasons for delay. This decisional delay, which I think is a useful kind of concept, perhaps, that, many people, and it'd be interesting to see where we stand at this point in time, but of those who are delaying, of course, many of those now have opted for a vaccine. There was a consistent need for more information about efficacy and safety. And so I think that's where really communication can come in around reassurance that there is evidence and information available to make those judgments. But as you can see here, people said rather wait a few months to see where it's going. I don't want to be pressured into. So they were actively still making this decision. They weren't necessarily foreclosing on whether or not to get a vaccine. And for many, utilization delay, a concept that we thought was quite useful, has a way of capturing those who said that, well, I'm going to refuse the vaccine until I absolutely have to take it. And for them, albeit controversially, they felt that vaccine passports, for example, might nudge them into getting a vaccine, or this notion that they would just make travel easier. And thus that was their kind of response as to why they would or wouldn't get a vaccine. But in some ways for them, delay was more a way of recapturing lost agency or control while they could. I don't want to get until I absolutely have to. Whereas for those who are kind of delaying for more decisional reasons, it was, again, they saw themselves as having agency in making their decision, but needed more information. So yes, happy to discuss those in more detail, but otherwise we won't have time for questions. So just wanted to say thanks so much for your time and the opportunity to talk about this project.
Thank you very much, Ash and Simon. They were both really stimulating presentations, and just trying to get my head digest the information. A lot of information there. So if anyone has any questions and answers, please put them in the chat. But firstly, just a question, I guess, from our team, just reflecting on what you might take home as some of the key sort of learning points, either in the application of behavioural science to potentially future pandemics, hopefully not. Are there any kind of key learning points, or indeed in terms of some of your research, Simon, and some of the things around adherence?
Do you want to jump in, Ash, or do you want me to go?
You go, Simon. Yep.
Yeah, no, thanks. I think, one key learning point, I suppose, I think that concept of alert fatigue seems to really resonate with me, and I think it's been quite useful. I think, so it's not necessarily that less is more, because you certainly wouldn't want to say, don't communicate and be transparent to the public, far from it. But I think, and of course, a lot of this was necessarily in real time, and nobody had a crystal ball and the ability to, as useful as models were, predict how long a pandemic was going to be and how much policy was needed and how many, policy kind of tweaks and adaptations and modifications were needed. But I think, it's something to bear in mind that over communicating, perhaps excessive information about policies, or indeed some of the kind of policy tweaks that in hindsight, which is always 2020, perhaps were tinkering too much, perhaps simpler policy and simpler information, and certainly consistency across the UK. But I'm fully aware there's a whole kind of political kind of sphere within which that topic lives. But I think that's one big thing for me, is striking a balance between providing enough information but making sure it's clear and not overwhelming. And then I think the other one is, I think the other important thing is around really what Ash was saying in regard to the combi. I mean, we definitely found, because we looked a bit at self-isolation as well, and what, even though again adherence was high, for those who didn't adhere, more often than not, it was for things that perhaps could have been addressed with the provision of capabilities or opportunities, whether that was financial or even more around things like the social and psychological challenges that people faced in order to self-isolate. So yes, again, easy to say in hindsight, but having a system where that was provided more consistently, particularly to those in need, I think would have been and could be beneficial in future.
Thanks, Simon. Ash, if you want to.
Yeah, I think I picked up some of those bits about not relying on our assumptions that people will be panic prone and selfish is really important. But where that comes from is a greater precision in our understanding based on data and intelligence. So data from an epidemiological perspective in terms of outbreak, cases and clusters and prevalence, etc. But then it's often called softer intel, but I think it's been shown to be really hard intel in the way that Simon's described about attitudes and beliefs and levels of trust. And it talks to Simon's point about alert fatigue. So being led by that intelligence will allow us to be more precise then. And that picks up the second bit that's critical, is about equity. Equity of intervention, because we recognise that there's an unequal and inequitable distribution of harm that we've seen from COVID in terms of ultimately succumbing, hospitalisation, acquisition, right the way through that. I did it the wrong way around, but getting it and succumbing to it has not been equal. That's because the difference is not just in behaviour, but in the influences of behaviour as well. So it's acknowledging those, I think, and making sure then that we account for that, using the data, so we don't generate more inequity in interventions that are well-meaning. And I think one of the ways that we do that is to think COM-B. It's not a silver bullet, but it would help if we just considered more routinely capabilities, opportunities, and motivations in that kind of space. And then I think there's loads of lessons. The other lessons about preparedness. Simon said, it was reaction in the heat of the battle, and hindsight is perfect. Just 2020 vision, but we could prepare more in terms of structures and processes and people, and we've got to hold on to some of those connections and collaborations and processes going forward. So when we've got the next one and the lessons, some of those lessons that Simon has, just outlined really well, we've got to take those into the next one. So we've got to think about loss, mental health, routine, structure, income before it happens next time. So we've got to build that lesson into, because we know they are key determinants, because we've got it now. We've got those data now. We've got to use those going forward. I'll stop.
Thanks. And we've had a couple of other questions. So there's been a couple of questions around something which is pretty prevalent throughout the pandemic, which was around misinformation and how we combat misinformation. So any, I guess, observations, reflections on how we can kind of combat that. That's one question. And then the second question is around, I guess, for both of you too, about how, just to expand a little bit about how a behavioural science approach or behavioural change approach can be applied to policy implementation. So two questions.
Yeah, so in terms of disinformation, we did some work on that, and that we've put a guide out. I mean, it's an area of expertise and approaches and proven approaches in it. Number one being non-amplification of the mis or disinformation to start with. So don't retweet that tweet was wrong because you've already amplified it. I'm just putting it really simply. But then strategies towards combating it with the truth. So not reposting it, but acknowledging the point that it's trying to bring out and looking at the behavioural foundation for it and messaging as much as we can the right, in inverted commas, the pro-social determinants kind of stuff. And then, but it gets to a point, so there is a sliding scale on it, and it does get to a point where you do challenge it overtly. So yeah, plenty of stuff around mis and disinformation to it. Application of behavioural science in terms of policy, yeah, absolutely. At the start, what's your policy aspiration? Is there a behaviour on that pathway to realising your policy aspiration? If there is, then it's worth the time thinking through who, what, why not, how can we hone our policy implementation to get there. Otherwise, what are we building policy on? An assumption of rational human being and rational response doesn't exist.
Thanks, Ash. Simon, do you have any reflections on those?
Yeah, I mean, those I think two of the big questions of our time, really. I mean, that question around misinformation, I mean, I think the pandemic has shone a light on how pervasive this problem is, and it's going to, it transcends the pandemic, really. I mean, I think in some senses, and helpfully from an operational perspective, for this webinar at least, I think, part of it is going to go right back to school and trying to, equip people with the tools to distinguish between. I mean, I think part of the problem with COVID, of course, is that it was such a nascent field of research. The experts themselves oftentimes didn't agree. Different types of experts were very vocal in different types of media. And I think it became increasingly, there was no unified kind of medical voice. So I think, at least in our study and just anecdotally, I think a lot of people struggle to know who is a credible voice because they had letters before and or after their name. So I think, just combating that is a challenge, I think. I mean, I think, again, just trying to keep on point around, what we have looked at in our study. I think, again, the problem with that alert fatigue, I think in the early stages, some of the official broadcasts were useful. I just think there was an element of fatigue that set in again. So trying to combat that, as well as somehow trying to fundamentally equip people to be able to distinguish between what is a credible source, because not all people were unfortunately looking at the NHS or the PHW websites. And then I think, behavioural science, sorry, that wasn't a very kind of useful answer in a sense, but I think it is a massive challenge that we're all going forward. And then in terms of the behavioural science, I think, what was interesting for me about this study is that until the vaccines came along, and even when they did, and even now the work that Ashley and others do are crucial, but behavioral scientists were the holding the fort until the cavalry of the immunologists and virologists came through. And so I think everything that we did, and much of what we still do, is all fundamentally tied to behavior. It pervades every policy, I think, that in some way or other, including vaccine uptake. So I think, again, trying to base it on, really just to kind of reiterate what Ash was saying, to base it on established theories, because I think, we were kind of chasing our tail empirically as kind of agile as our project was. And I'm quite proud, looking back, how quickly we were able to turn the data over and kind of maintain that kind of robustness that you need for scientific research. You're still kind of collecting data, and by the time you publish it, it's kind of hard. The virus is always going to move quicker certainly than peer review. But nevertheless, I think, as Combi has shown, you can still take these frameworks that apply to other public health domains and apply them with good use. And similarly, we can take what we've learned from COVID and hopefully reapply that to everything from smoking cessation to, nutrition-related eating behaviours and so on and so forth. So I think, again, just trying to build up from some of these frameworks, there's always going to be value in that.
Great, thank you very much. It doesn't look as though we have any more questions now. So it goes from me and the audience to say a really big thanks to both of you. I don't know if you had any final or concluding thoughts that you wanted to share with us.
Ash, have the chance. No, good session. Yeah, great to be able to share it with you and build a community that are involved with applying behavioural science. I believe, obviously, but up to others to drill and find out more.
Yeah, and thanks to everyone on the call. I'm just looking at some names and affiliations for all the amazing stuff you've done over the past 2 years. Appreciate it.
Thank you. Thanks. So that's all we have time for today. So many thanks to Ash and Simon for the presentations. We'd be grateful if everyone who joined the webinar today completed a short evaluation, the link which was put in the chat. And if you're not already a member of Public Health Network Cymru, we would invite you to join by looking at our website. And if you have any final thoughts for future webinars, then please contact us. Diolch yn fawr. Thank you.